fears today and helping their parents out. And Laura, you can move to the next slide. We have no financial disclosures. If you want to move ahead.
One second, I'm trying.
Oh, okay, you're having technical difficulties.
There we go.
There we go. We have nothing to disclose. So what we're talking about today is first we're going to start talking about the basics of toileting just to make sure we're on the same page, and then anxiety related issues that can cause children to avoid toileting. And then we'll talk about how to help. So recommendations and explanations that can be helpful for parents, particularly with young children who are wanting to avoid toileting. And then finally, we'll talk about referring and recognizing when you need to refer for further intervention, and then how to refer to the Avoiding Improvement Partnership Clinic that Dr. Fuller has in the Department of Urology. So toileting, what's typical? It's helpful for parents to know. Children start to use the bathroom or be toilet trained around 24 months. And by the time they're 36 months of age, 98% of them are toilet trained. And by the time they start school, most children are toilet trained. So there is a range of window there for you to work on toilet training and give kids, some latitude over when they're ready for that. And on average, girls achieve control sooner than boys do. The typical sequence of bowel and bladder control might also be helpful for parents to know. What is typical is that children become continent at night with holding their stool, and then during the day follows next, and then followed by daytime bladder control, and then finally controlling their bladder overnight and not wetting in the evening or overnight. But we're here because toilet training isn't always easy, and sometimes there are potty problems. And so the American Psychiatric Association recognizes two elimination disorders, enuresis and encapresis. The diagnostic criteria for enuresis includes like repeated wetting accidents, so voiding of urine into the bed or clothes, and that's either if it's voluntary or intentional, doesn't matter, and that it's a clinically significant behavior both in frequency and duration, so at least twice a week for at least 3 consecutive months, or that it causes clinically significant distress in a variety of areas. And it's not diagnosed until children are age 5 or equivalent developmental level, and that's because we don't expect all children to be completely potty trained until that age. And we always want to make sure there is no medical reason or it's not a side effect of a medication or a substance. So if it's attributable to something else, we would not diagnose enuresis. And similar with encapresis, this would be when children have passage of feces into inappropriate places, again, like their clothing or floor. And again, if it's involuntary or intentional, does not matter. And less frequent, so at least only 1 event per month is needed for this diagnosis and for at least 3 months. And the chronological age is younger, it's 4, and that kind of goes along with the sequence of typical development for children. And again, it's not attributable to substances like medications or another medical condition. So it's a little hard to find information about the prevalence of toilet anxiety and urinary issues. What I could find was more related to, there's more information from like the UK. And so this first bullet point was from a website that in the UK that talks about toileting issues and mentioned that in studies, typically 4 out of 30 children who are in their first year of going to school have toilet anxiety. So it's over 10% that are affected by this. And then worldwide, when they're thinking about like what you would consider a shy bladder or kind of that social anxiety around urinating around people, that there's a wide range of about 2 to 16% of people worldwide have social anxiety around toileting specifically. And there are several reasons that children have anxiety around going to the bathroom. Simply, some of them are worried about things like falling in the toilet, loud noises associated with the bathroom, like hand dryers and loud toilet flushing, especially the ones that are automatic. And then being in an unfamiliar space, some kids are more comfortable using the toilet at their own house, but when they go out into public or go to school, it causes them a little bit more anxiety. And sometimes that's because of social anxiety. So embarrassment of someone else hearing you go to the bathroom or being teased by peers, kids will worry about that. Another reason kids might have anxiety around toilet training is depending on how their interactions with their parents have gone during toilet training, and has there been what's like punitive consequences for wedding accidents or stool accidents, and so they're worried about negative consequences for themselves. And then some kids have sensory sensitivities, and we will talk later too, but specifically kids who may have an autism spectrum disorder diagnosis or ADHD or even anxiety may be more sensitive to different aspects of toileting that make it more likely that they don't really want to go. And one of the ways that they may be more sensitive is to painful defecation. And so we'll talk a lot about today about constipation and the effects of constipation on toilet anxiety and how to treat that to help reduce toilet anxiety and have more success with toileting. When we talk with families and caregivers about the cycle of anxiety, there's a reason why children develop this kind of pattern. So they have an urge to go to the bathroom, and it makes their anxiety increase and their worry increase about things like painful defecation or making a mistake or falling in or those kinds of things. And so then they avoid going to the bathroom by holding their urine or holding their stool. And so then in the moment, their anxiety decreases because that stressful situation is kind of past. And over time, kids get better at holding, whether it's holding their pee or holding their poop. But eventually they get to the urge to go to the bathroom again. And so sometimes this is when we can see these accidents. So they may have wedding accidents because their bladder is simply too full and they can't hold it in anymore. They may have soiling accidents similarly, or they may be constipated and have leakage accidents. So it's kind of this cycle that, there's several iterations of this. It's not like it's a one and done, but there's a lot of iterations of being anxious about going to the bathroom, avoiding the bathroom, and having that anxiety decrease in the moment for the short term, but then having more problems over time.
Thank you, Kari. That was a wonderful review. We're going to delve a little more into toileting anxiety and what it is and how to help. I wanted to clarify that one way that you can classify these kinds of issues is toilet phobia versus toilet refusal. Toilet phobia is very rare. I've seen it a number of times because of the special place where I work, but in general, it's rare. It's a situation where toilets are avoided completely. It can be associated with somatic or physical concerns and behavioral concerns in the child. And the child might need some behavior therapy, such as exposure therapy, which we'll talk about in a little bit. And usually they need kind of a graduated approach where you work with them over time to get them doing more and more of what they need to be doing. Toilet refusal, though, is pretty common in toddlers. It's where the child won't urinate or defecate in their diapers. They will go in their diapers and they won't sit on the potty or go in the potty. And it is associated with high rates of constipation. There's that word again. We'll talk about it some more pretty soon. And also some behavioral concerns. So when children have toileting anxiety and toileting problems, there are, of course, negative outcomes. For those of you who've worked with this population, you know that there can be medical complications such as urinary tract infections and occasionally like kidney infections that are even more concerning. Psychosocially, there's low self-esteem that can be associated with this. Kids may not be able to, or may not want to, or parents may not want to send their kids on overnight visits or to camp, or it may interfere with the child's ability to socialize because they're having accidents and they can't go stay at a friend's house or they're afraid to. There's social rejection. Some kids get teased by peers for being a child who smells like urine or feces, or the kid who has to go to the bathroom and use, a certain toilet or something like that. They may, of course, experience embarrassment about these issues. Some kids show angry outbursts. Some have a prolonged course of continuing anxiety and toileting accidents. Of course, there is also the lost time that they could be spending doing other things that they want or need to do, like schoolwork and socializing activities. So kids who have to go and change their clothes and clean up a lot may be missing out on instruction time at school or sports practices or playtime. And for parents, we hear this and see this a lot. It can be pretty frustrating, considering that many kids are toilet trained well before they start school. Some parents we see kids who are 8 or 10 or 12 or 15 in our clinic, and the parents are tired of having to buy incontinence products, do mountains of laundry, sometimes pay for, new like mattresses for the beds, things like that, or the smell of a house where there's lots and lots of incontinence going on can be frustrating and difficult for families. So lots of things to consider that are associated with these kinds of problems. So in my experience, what I think I see a lot is that primary care providers vary a lot in how much of this they are comfortable or able to deal with this in their own office, and how much they would prefer to refer to a specialty clinic such as ours. But in general, whether we're talking about like a primary care office or the clinic, the specialty clinic that we do through pediatric urology, many times the workup involves medical evaluation, analyzing urine to see if there's UTI or, high blood sugar, lots of different things that my colleagues in urology take care of, and I don't have to think too much about, but it's great having them in clinic with me so that we're both thinking about all the things that we need to be thinking about to treat these kids. There's also usually a physical exam, and sometimes there are all kinds of different things that are going on that could be inhibiting a child's ability to void the way that they're expected to. And it, very rarely it ends up being something like a tethered spinal cord that is causing them to lose control or sensation. But it can also be like when the nurse practitioner that I work with palpates the child's abdomen, they're full of stool. That's the most common thing that we see. But as part of the evaluation, of course, we also consider the child's family history. Kids with voiding problems are often children of parents who have a history of voiding problems. It's more common, it runs in families. There are psychosocial factors that may be evaluated as well. Anything from, what's this child's schooling situation and how are they handling the toileting at school? Or are there other children in the family? Is there a young baby? And was there a setback after a baby was born? All kinds of different psychosocial factors. You also want to get some handle on the child's perception of their own problems, whether they want things to get better, whether they're interested in changing. That's always a hopeful sign for me, but not always the case. And sometimes they did care and have a lot of interest at one point, but they've gotten discouraged over time. It's also good to find out about the history of the problem. We've met kids who have, like significant trauma or losses or things that happened right before the potty problems. And then sometimes the evaluation also involves referring the child for further evaluation, including to psychology or psychiatry or somewhere else. And certainly if it's anxiety related, then it's good to mention, here's a kid who seems to have a lot of toileting anxiety, or here's a kid who seems to have a lot of general issues with anxiety that are affecting them with their toileting. This is not showing up right. Can you see it, Kari? Does it show just part of the Bristol stool chart? Okay.
Yeah, it's not showing correctly.
What this slide is supposed to say is that poop is a frequent culprit. If there's one thing that I want to kind of get across to people today, hopefully we'll get across more than one thing, but constipation and poop problems are very often associated with urinary problems and daytime wetting. And so if you're familiar with the Bristol stool chart, which isn't showing up very well here, it goes from a range of little rabbit pellets or hard lumps of stool to lumpy and sausage-like kinds of stool, to type 3, which is more like a sausage shape with cracks in the surface. 4 is a smooth sausage or snake. 5 is fluffy with clear-cut edges. 6 is ragged edges, and 7 is liquidy stool. And we show this chart and we talk to families a lot about it because it's important for us to know how much of a problem this is. I will say that some parents think that the child isn't constipated because the child is having liquidy poops, but what is really happening is that the child has a ball of stool that isn't moving out of their rectum, and the softer, more liquidy stuff is coming around it and leaking out. So I'm sorry if you guys are eating lunch, because that's not maybe the thing you want to hear while you're eating lunch, but it is a reality, and sometimes parents will not be aware that their child could be constipated. They're confused by the liquid poop. So several recommendations to share with you, and we'll talk some more about this also. But we think that a big part of this is managing parents' expectations or caregivers' expectations and clarifying the child's and parents' role in treatment. If a child is not super interested in working on this, then there is almost never like some magic thing we can tell them that will change that right away. We do a lot of education and things like that, but helping parents to know that they're going to have to be involved, even if they're kind of tired and worn out from doing this for many years. They are going to have to be part of the solution, most likely, to help get some new habits established. We really encourage parents to use a non-punitive approach. As Kari mentioned, oftentimes highly punitive toileting experience when a kid is young can be a setback or even traumatic for the child. So in our clinic and in the literature, a big recommendation is to make sure and treat constipation. And this is done by increasing hydration, making sure the child is drinking plenty of fluid each day during the day, not at night, hopefully. And, we see this especially in the summer, like if kids aren't drinking enough water during the day, they're super thirsty at night, and that's not a good pattern to be in. So helping them make sure they're drinking plenty. Medications are often used. I see Miralax being used quite often as a stool softener. It's not as common to use things like laxatives because they can actually cause more problems if they're used long term. Another way that constipation is treated is with toilet sits after meals. Some families prefer to use more like dietary measures, trying to increase the fiber in the diet or giving a fiber supplement. And we always try and really, really emphasize to get the child drinking more water. Otherwise, increasing fiber alone can increase constipation. So you've got to get the fluid in there to help the fiber work. We also hear and see in the literature that a lot of dairy can be constipating. So for some kids, if they're drinking mostly milk and not a lot of water, we encourage them to swap out water for some of the milk they're drinking. We definitely encourage kids to completely relax. Well, not completely relax when they're on the toilet. We want them to be able to stay seated on the toilet, but they need to be able to relax their belly muscles and their pelvic floor muscles. So if they can't sit with their feet flat on the floor when they're sitting on the toilet seat, then we encourage them to have a step stool or a squatty potty so that their feet can be supported and they can relax the pelvic floor muscles. Sometimes having the child do something relaxing while they're on the toilet, like listening to music or doing something enjoyable while they're sitting on the toilet, using breathing techniques like a big deep sigh or blowing bubbles or blowing on a wind pinwheel kind of thing can be helpful. If you tell the child to blow a bubble or imagine they're blowing a bubble, it needs to be a slow, big bubble, not short, choppy breaths. We want the slow, sustained kind of breathing to help them, again, relax their pelvic floor muscles. And then we recommend scheduled toileting every couple hours during the day for the child to try to urinate, if that's what we're working on. And the other key here is that you have to have them do this for a long time. And we're not talking just weeks, but if it's a pretty entrenched problem, they're going to need to probably go to the bathroom on a schedule for months and years. So we try and talk to the families and children about this because they abandon the schedules too quickly sometimes. So we have to encourage that they keep following the schedule. And we have to also tell the kids that they need to go even if they don't feel the need to go. That's another key, because if we're just relying on them going when they feel the need to go, that has not been working. They wouldn't be coming to see us if that were the case, if they could tell that they need to go. And sometimes kids who are anxious, like they're afraid to speak up in class and interrupt things, so they may need some extra support in order for them to be able to do this scheduled toileting thing at school or at other places where they're worried about speaking up or sticking out. Okay. So another recommendation that we talk about is reinforcement. And this could be reinforcing the child for taking their medicine, drinking their water, doing the timed toileting or scheduled toileting sits that we're asking them to do. So we usually, especially in the early phases of treatment, we really want kids to be rewarded for doing what's recommended, which is doing the toilet sits, for example. So it's not that we're rewarding them for staying dry, we're rewarding them for going to the bathroom on a schedule, for example. And that's important because a lot of parents and schools will put plans in place where the reward comes for the kids staying dry for a long period of time. And we want the rewards to be more immediate than that, so that they can be effective. We usually use some kind of a potty chart or calendar to help with that. Another way that providers can help support these kinds of recommendations is by providing medical notes for bathroom breaks, or for teachers to give reminders, or for the child to have a water bottle at school. You would be amazed at the variability in schools and whether or not they automatically allow these things or whether they need notes for these kinds of things. Sometimes a recommendation is to have the child go to pelvic floor physical therapy and learn how to relax their Kegel muscles or their pelvic floor muscles. So you need, if you send a kid to a pelvic floor physical therapist, you need to send it to somebody who knows how to work with kids. If they're used to working with postpartum women, they may not know that this is a whole different set of exercises and that we're focusing on relaxing the muscles instead of tightening them up. So a lot of kids with voiding dysfunction who've gotten to be really good holders have super strong, like Olympic grade pelvic floor muscles. And their problem is that they don't know how to relax them and coordinate that very well with the voiding. Another recommendation or thing that we do is provide psychoeducation about anxiety. We have some books and materials we show kids in clinic, and things we recommend to parents about anxiety and also about toileting, as a matter of fact, and just help them understand how their body system works. Something that is often recommended is exposure therapy, which is a kind of behavioral therapy where you develop we call it a fear ladder, a fear hierarchy that helps the child identify things about toileting that make them anxious. And then you kind of rank them from lowest to highest in terms of how anxious it makes them. And then you have them start doing some practices where they practice exposing themselves to the thing that they fear. And of course, not a lot of people want to sign up for therapy where you have to just constantly expose yourself to things that cause you fear and anxiety. So we do give them a good rationale for why this is done, and we try and make it worth their while by putting reward programs in place. With older kids, that's not necessarily not always necessary, but for younger kids, for sure, they're a lot more invested if they're getting a reward for doing the exposure therapy practices. We'll talk some more about that in the case examples. Another thing we do quite often in clinic is problem solving things that might be barriers to toileting, whether it is something that's going on that just requires a doctor's note for the school, or whether it's something happening like the kid is scared to get out of bed at night because it's dark, and once there's a night light, things get better. So just problem solving, we'll have an example of that in the case examples too. Another maybe kind of underused approach, I would say, is taking a break for a while. With these anxious kids who are just a ball of stress about anything related to toileting after a while, sometimes just saying, we're going to back off and take a break for a while and come back at this in a month or two, something like that. When we talk to the parent and the child about kids who have toileting anxiety, sometimes we frame it for them in terms of a worry bully, or, kind of a worry monster, or maybe we have them give it a name or something like that, and talk to them about the fact that when kids have worries, that's normal. Worries and fears tell us that something seems to be harmful, or that we think something might hurt us. But we also explain to the kids that sometimes we take that a little too far, and there's like a worry bully in our brain telling us that we need to avoid something that actually won't hurt us. And it might be something that we need to do, or something we might enjoy doing that we're not getting to do because of all of our worries and fears. So that's one way that we try and frame things. Another way we try and frame things for kids and parents sometimes is that we explain to them about how the kidneys are always producing urine, the bladder is always filling up with urine, and that if you don't go to the bathroom often enough, your bladder is going to get bossy. And we'll even, like in the clinic room, we'll demonstrate sometimes with a cup under a faucet and show them how there's always liquid coming into the bladder. And if you wait too long and then you try and run, with a very full bladder, it's gonna leak, or it's gonna come out as an accident. And we try and help them understand why they would want to follow a schedule for toileting instead of just trying to wait until they feel the need to go, which might be too late. Another way that we talk to these families sometimes is that they're not alone, and that they're not the only kids in their class or their age who are having these kinds of issues, that it's more common than they realize. It's just not something that's talked about very much. As I mentioned before, we will also try and explain to parents that there's usually not something that we can just say that will suddenly make the light bulb go on. Occasionally that happens, but usually the kids who come to us in clinic are there because other people have already tried, including they have already seen a provider from pediatric urology once or several times before they come to our special clinic. And we also introduced the idea that many families do better when they work with a coach, i.e. therapy, and try and set the stage for maybe having them work with somebody on some of these things. So there are a lot of resources that are available. The Pediatric Gastroenterology Service, I know, has recommended to many kids a video called The Poo in You for kids who are constipated or having poop problems. These next two websites are really great. One is from Lurie Children's at Northwestern about when your child is scared to poop in the potty. It really gives some great step-by-step instructions for young kids in particular. And these resources from the UK are great also. And of course, I love the British dialect and how they talk about making poo less scary and stool withholding, and children who will only poo in a nappy, which is a diaper for those of you who are not fluent in British. I think that's really adorable. There are some books here. The first several are for younger kids. The fourth one we use in our clinic, it's like one of those lift the flap books that show the different body systems, and we do some education on the excretory and urinary systems. Timer watches there are a lot of timer watches now that will vibrate, and you can set them for every couple hours during the day, and those can be reminders for the child to go to the bathroom on a schedule. We send home sticker charts a lot. There are lots of sticker charts available out there online. And then we also use visual schedules and recommend those a lot in clinic. And those are like schedules like what the morning routine is or what the bedtime routine is. Another resource is sending them to our clinic. We'll tell about that on a separate slide, referring them for therapy. And then these last two, as far as I know, they are still offering only telemedicine treatment and offering it for people with private insurance, but they do really good work. And they work with people who have anxiety and obsessive compulsive disorder types of symptoms. When to refer? We want providers to think about referring to a specialty clinic or specialist if the child isn't making progress with increased hydration, stool softening, and timed voiding, if they seem really complex, or you think that they, for whatever reason, they need additional intervention, if they have frequent or recurrent or febrile UTIs, if their incontinence is getting worse, if they have a history of neurological or anatomical genitourinary issues. And sometimes just right off the bat, you want the specialist to manage like anticholinergic therapy, like oxybutynin or things like that. Okay, the way you refer to our special clinic in pediatric urology is to just first send a consult to pediatric urology at UIHC. And there are providers who will see the child first and rule out medical causes. They are located in the main hospital, at the Iowa River Landing, and at several like outreach clinics in other parts of Iowa, like Dubuque and Davenport and things like that. If they come to our voiding clinic, they are seen by a team together of a pediatric urology medical provider, not always a pediatric urologist, but a medical provider from pediatric urology and a child psychologist. I will tell you, we've done a little research on our clinic population, and anxiety and ADHD are by far the most common like psychiatric issues going on with the kids we see, and we see all ages. We'll see kids occasionally below age 5, but we also see lots of teenagers. So now moving on to what I think is the most interesting part, which is case examples. I'll start us out and then Kari will finish up and take us into the home stretch. This actually is probably several children I've worked with, but one was a 3-year-old little girl who was referred to me by a pediatric urologist because she was terribly afraid of going to the toilet. She would not sit or go near the potty. She had a severe constipation history. And we worked with the medical provider first to get the stools very soft. We worked on having the child just practice sitting on the potty with their pants on, with their diaper on, just so that they could get relaxed on the toilet before we ever started working on going potty in the toilet. And once she was very soft with her stools, we would have her sit at a time she was most likely to have a bowel movement, and she would have one in her diaper. And then, I don't know, this happens with a lot of kids we see. Things just took off from there, and it didn't take long for her to start pooping in the potty. And it really just took a few sessions with this family because they were on the ball and they kind of understood what we were trying to do. I will say that parents who are really committed to working on these things with their child and who have good kind of organizational skills and non-chaotic home environment are probably, in my experience, more successful, as you might expect, with helping these kids do these kinds of therapy recommendations. Another kid we've seen a number of times, he was 9. He had extensive constipation as well and was having lots of wetting accidents. And he had a lot of stress that had happened to him right around the time that his toileting issues started up. He'd been fully potty trained and continent for several years, and then a bunch of things happened. The pandemic, a serious medical issue for one of the parents, all kinds of different things. When they came to see us in clinic, the child was on what's called the MOP protocol, or the modified O'Regan protocol. And some of you may be hearing about this in your own practices, but it's popular with some families, and it involves a lot of like daily enemas. And it's amazing because some kids really like tolerate that very well, and it can help them, I guess, get more control over their constipation. With this boy, that protocol seemed to be working well, so we didn't mess with it, but we did work with him on the toileting phobia, as I previously described. We came up with a fear ladder for him, and we had him practice some exposures to things that he feared. We didn't start at the top, most scary things. We started lower down and had him work his way up. He, first we would just have him go in the bathroom and stand near the toilet. And then, we worked our way up to scarier things like going into strange bathrooms or going into bathrooms that weren't very clean. And he eventually was able to get where we wanted him to be with regard to being able to have, to be able to urinate and have bowel movements in toilets at home and out in public. We saw them recently, and they had quit doing these kinds of things, the rewards and the exposures, and he got worse again. So we had them start back up with that. A combined therapy approach that we used with a young boy who had both ADHD and anxiety. We got evaluation for him with a psychologist, diagnosed the ADHD. He got on medication, and he got in therapy for his anxiety. And doing those things together and having parents get on board with a behavioral reward system for him brought about a lot of improvement for him. We've seen a few kids with Hinman syndrome or something approaching it. It's a very rare condition where the child withholds going to the bathroom to the point where their bladder stops working very well. So this girl, when we first saw her, started out with having voiding problems and a lot of withholding, but she had been having the problems for so long that she fairly soon had to start catheterizing in order to keep her kidneys from being harmed further than they already had been. And eventually she had to have an even further medical procedure to keep the pressure off of the bladder. And I think some of the start of this was anxiety, but it wasn't just anxiety. It was a variety of things going on with her. Okay. One of my favorite things to talk about is collaborative problem solving. One recent example was an 8-year-old boy. He had a history of bladder exstrophy and also a severe like hypospadias condition where the urine didn't come out of the end of his penis, but came out of a hole kind of on the top. And so it was very hard for him to urinate into a toilet. And he was refusing to use the toilet. And as we problem solved with him, we eventually figured out that that was why he was avoiding the toilet, because the urine would just spray everywhere and he would get in trouble for that. And we actually found a product that would help like act as a shield so that it would direct the urine into the toilet instead of spraying all over the place. And problem solving with kids about the barriers to their toileting is very helpful. Kari's going to take it from here.
Thank you. Yeah, so I was going to talk about a student I worked with when I worked in the school setting. I worked with him for several years. He was 16 around the time that around the time that we were working on this together. And he had autism. He also had intellectual disabilities, and he was pretty severely and profoundly disabled. But and so we saw him in the school setting. And when he was at school, he would wear a pull-up. He was continent, so he could urinate and defecate in a toilet if given the opportunity, but he was also would just urinate and defecate anywhere as he wanted. So what we did with him was we established a visual schedule. So again, getting back to that timed schedule, toilet schedule, he had it on a visual schedule he could see in the classroom, so he knew when he was coming. And what we did was when it was time for him to go to the bathroom, as soon as he would sit on the toilet, he would get an immediate small reward. So the point of this example really is that sometimes kids need that reward to be very immediate. And then after, he would sit for a few minutes and he would typically go to the bathroom. He would get another immediate small edible reward and then wash his hands and kind of get back to the classroom. But for him, we had to keep this in place. So getting back to what Dr. Fuller said about like sometimes it's a several years long process of scheduled toileting and reinforcement. He had been toilet trained previously with a similar kind of program, and that was a schedule and reinforcement they were going to have to keep up with him for many years, if not for the rest of his life, to keep him going on the toilet and to reduce the accidents he was having in other locations. But it can be done. Do you want to go to the next slide? So kind of our takeaways for today is that toileting anxiety and fears are common. And like Dr. Fuller said, that toileting phobia is more rare. And the first thing we want to do is make sure there aren't medical causes. And then the main approaches really are about treating constipation, like you've heard about a few times today. So increasing fluid consumption, making sure they're on stool softeners if they need to, have that timed toileting schedule, and really letting parents know and getting parents to understand that it's going to be something that's not going to change overnight or not with just one bowel movement, but that you're going to continue to have a toileting schedule and continue to use these interventions for quite a while. And then, with some kids, they may need additional intervention. So exposure therapy, like Dr. Fuller talked about, or other psychotherapies, medications, and in some cases, pelvic floor physical therapy. And if you need to make a referral, you can refer through the University of Iowa's pediatric urology clinic to get into the Avoiding Improvement Partnership clinic that Dr. Fuller has. So to sum, we also want to thank all the medical providers in pediatric urology. Dr. Fuller's worked with several throughout the years, especially Dr. Storm, Cooper, Lockwood, and Edwards, and Chris Bonnet, who currently does the VIP clinic with Dr. Fuller, and the child health specialty clinics, and then all the patients and families that we really learn a lot from when we work with. And then there are some references that we provided for you. And on this slide, Dr. Fuller's email is on there if you have any questions you want to email her later.
So we did get coffee. Do you have some you want to start with? I know we have the list of the webinar questions that were pre-submitted.
Yeah, and I think you covered a lot of those, so thank you so much. We did have a question that came in the Q&A, and I'll just read that for everyone to hear. I've been told that children who feel out of control often use toileting as something they can control. Is this something you see in your practice?
I would say definitely yes. that we see that a lot. And kids who are anxious definitely, sometimes try and control the parts of the environment or the parts of their life that they can control. Not just kids with anxiety, but it definitely comes up with kids who have anxiety, where if we all want to avoid things that scare us. And so if we can control going to the bathroom, then that's one thing we take off the list of scary situations that we don't have to be in, except that after a while our bodies override that and make us go anyway. So that's why it's not such a good solution to withhold or to hold in stool and urine.
Great, thank you. Another question, I know you mentioned that sometimes families, stop the therapies kind of prematurely. How long do you recommend families to continue with therapy or other treatments?
That's a great question. And I think it depends if we're talking about more like psychotherapy, pelvic floor physical therapy, timed toileting and stool softeners and things. In our clinic, we tend to follow people like every 3 months, every 6 months, every year, whatever is the appropriate amount of time, just so we can check in with them and make sure that we're helping them stay on top of constipation, scheduled voiding, and things like that. But I'd say at least a year for, if a child has had pretty entrenched problems with voiding dysfunction, daytime wetting accidents, or constipation, then they need to be on their toileting schedule and having soft bowel movements and drinking plenty of water for over a year, probably, before we would really suggest to them that they can move on to just going when they feel like they need to. There are kids who defy the odds and get it quickly and stay well, but I'm talking about those with really, really kind of entrenched problems. As far as the pelvic floor physical therapy, the providers are really good about telling families when they think they're done or when they don't think they can make any more progress right at that point. And for psychotherapy, same deal. I find that if somebody works with me or somebody else in a very focused way on just these things, that we can get done in 8 to 12 sessions most often. If we're going to see progress, we'll see it in that amount of time. But there are also families who then say, now we want to work on some other things, or that kind of thing. But I would say that if you're not seeing results in 8 to 12 sessions with the behavior therapy, like exposure therapy, then it may not, you may need to do something different, either find a different provider, find a different approach, take a step back and make sure nothing's been missed medically, etc. There are lots of options. I will also just make a quick plug for parents of really, really anxious kids who are generally anxious. In our clinic, we do offer a therapy called SPACE, which is supportive parenting for anxious childhood emotions. And that teaches parents to actually do some things to help the child not avoid things. And it is therapy that we do with the parents. So that's a topic for a whole other webinar, but it's good for people to know about too.
Oh, thank you for that great resource. And then there was a question if participants could get access to the slides. I know there were some great resources that you included.
Yeah, I can send those to you and you can send them out, right?
Yes, I sure can. Thank you.
Yep.
And then maybe we have time for one more. Are there ways that parents can work within the schools? Because of the, I imagine it's challenging, for school staff to, help, dedicate that time to help with, supporting like the schedules and things, but are there ways in which parents can collaborate with school personnel and help support some of the plans and treatment recommendations? Or are there things providers can do?
Yeah, these have all been great questions. Dr. Kempf, I think I'm going to toss this one over to you if you're okay with that.
That's fine. Yeah, I mean, I would say in the VIP clinic, Chris Bonnet, who is the medical provider, she will often write notes giving permission for kids to do things like have scheduled toileting routines at school, like going every 2 hours. And, I think it really depends somewhat. It depends on the age of your child. Like, so in kindergarten, first grade, schools are more often having like scheduled bathroom breaks for the whole classroom. So working with the teacher, just so that they know maybe your student needs more guidance and encouragement to go on those scheduled toilet breaks. When there are really significant concerns, you can work with the school to have a more formalized toileting program or plan. So not even just that note to go to the bathroom, but things like having a water bottle. Sometimes there's nursing assistance that comes on with an individual health plan. Having teachers or school staff support practicing going to the toilet or sitting on the toilet or going to the bathroom. So it can really vary depending on what the child needs. And also it does vary a little bit with what schools are willing and able to do with the resources they have as well. But you can get a lot of support from schools when you have things like a note from a medical provider and parents who are good advocates about how you can work together and team together.
Thank you very much. Okay. Well, it looks like we're getting close to time. There was one more that says this is a really important topic and one that creates embarrassment and distress in families. Do you have suggestions to communicating with and involving other care providers, schools, aides, teachers, et cetera? So that you kind of did cover that, I think. But please let me know if you want to add anything else.
I do think normalizing it, they're not the only child who's having these problems, is really important. And to just take a very kind of matter-of-fact approach and encourage people to just deal with this as a medical issue.
Great, thank you. So I'll cover a couple housekeeping announcements before we close. This course was certified for AMA PRA Category 1 credit. Attendees are eligible to claim continuing education credit by completing the evaluation and attestation form and downloading your certificate of participation. The step-by-step instructions on how to claim credit are in the chat, so please feel free to download that. And I'll also send this information in the follow-up email. But don't hesitate to reach out to me if you have any questions. My email is kafi-dixon@uiowa.edu. So in closing, I just want to thank Dr. Fuller and Dr. Kempf for a fantastic presentation, and thank everyone for attending today.
Thank you.
Have a great afternoon.